And this month we have an interesting case presented from the Department of GI Surgery at Caritas Hospital. Dr. Jitin will be presenting a case of blunt trauma where Whipples resection was done. So without wasting much time, let me ask Dr. Prathapan to take over and conduct the proceedings.
Good evening, Dr. Joshi. First of all, I thank ASGK for giving me this opportunity. I can see my sir, Dr. Shubhalal sir in the gathering. So, pancreatoduodenal trauma is a very rare happening as a single isolated trauma. But many a time we may have to manage pancreatic trauma when it occurs as part of other blunt trauma. So today we have an interesting case of pancreatoduodenal trauma from the most what you call the prime GI center of Kottayam Caritas Hospital. Dr. Murali and his team is presenting a case of pancreatoduodenal trauma for which the Whipples resection is done. So I'm waiting for why Whipples resection and what are the problem which led to Whipples resection in pancreatoduodenal trauma. Over to Dr. Murali and Dr. Jitin.
Hello. Hello, I've just shared my slide. Is it visible?
Yeah, it's visible.
Yes, it is clear.
Okay. So today I'll be presenting a case about an emergency Whipples procedure in a blunt pancreatoduodenal trauma. The case I'll be sharing with all of you is the case of a 17-year-old boy with an alleged history of fall from bike. He was the pillion rider on the bike. He was taken to a local hospital initially. Over there, a CT scan was done. The films are not with us, although the report suggested that it was a grade 2 duodenal injury with a grade 2 pancreatic injury and a grade 2 hepatic injury. And the patient was referred to us in about 4 hours from the time of injury. And we are seeing the patient after 4 hours. This was the gist of the CT report that was done from outside, which showed a laceration in the liver at segment 5, the pancreatic head being enlarged, thickening of the duodenum and small bowel loops. And there was a suggestion of a blotch of contrast in the periduodenal region and hemoperitoneum. On presentation to us, while we have seen the patient in the casualty, he was hemodynamically stable. His abdomen was soft, not distended, with some mild epigastric tenderness. So we decided to admit the patient in the ICU, in the surgical ICU, for observation and to provide analgesia. Now, these were his labs on admission. His total count was at the range of 21,000. Platelets were around 2.4 lakhs, with the INR was 1.4. Amylase and lipase were on the higher side on admission. That was 240 and 697 respectively. Mind you, these labs were taken at the time of admission at our hospital. That was 4 to 5 hours after the onset of injury. Bilirubin at the same time was 2.6 with the transaminases at 118 and 92. Albumin was 4.1 and sodium potassium were 132, 3.1. His hemoglobin at that time on admission was at 12.7. Now, after his admission, we had decided that since we had a CT from outside, which has shown the following findings that I mentioned earlier, we had decided to stabilize the patient first, provide analgesia, make him comfortable, and to perform another CT, a relook CT after 48 hours from the time of onset of injury. So his course over the next 48 hours in our ICU, he was hemodynamically stable. There was no drop in the hemoglobin levels, although his amylase and lipase levels were elevated as compared to the initial values. Amylase was 553, lipase was 770. These were the CT findings after 48 hours of admission. There was a duodenal hematoma with a narrowing third part of duodenum. Air pockets were noted in the right paragolic gutter, which was suggestive of a contained perforation. As suggested previously, there was a hepatic laceration, which was in the caudate lobe and segment 4B. The head of the pancreas was bulky with multiple lacerations. There was some peripancreatic fat stranding. There was no active contrast extravasation from the stomach or the duodenum. These were the CT images procured at our hospital 48 hours after the onset of the injury. Now, during the course of the stay, during that initial 1 week, initial 7 to 10 days, his serum amylase and lipase levels were continually on the rise. But we managed him conservatively. We kept him nil per oral on a continuous rise tube aspiration and with adequate analgesia. On the 5th day of admission, it was noted that he was complaining of some nausea and vomiting. The vomitus was mainly of bilious in nature. And the Ryle's tube, the aspirate, was around 1.5 to 2 liters, if not a little more than 2 liters. So we were suspecting possible gastric outlet obstruction at this point. This is just a small slide just to give you information on the preoperative nutritional optimization, that is prehabilitation, that we routinely do to most of our patients who are either undernourished or with chronic disease, with a low BMI value. We usually admit them a few days prior to the set date of surgery, optimize them, build up their nutritional levels, build up their albumin levels, may or may not give supportive parental nutrition. So I just want to put this word out here, prehabilitation. Now, as I suggested, on the 5th day of his admission, it was noted that he was having bilious vomiting, and we had a diagnosis of a gastric outlet obstruction. As was shown in the CT that I had just shown earlier, there was a narrowing because of the hematoma in the third part of the duodenum. So we had decided to go ahead with a damage control surgery at this point. We had decided to go in to provide a bypass. So we went ahead with the laparoscopic assisted loop gastrojejunostomy, and keeping in mind that he might require further surgeries or anticipating a rocky road to recovery, we also put in a feeding jejunostomy at that time. There was a moderate amount of intra-abdominal collection which was drained, and a drain was placed. The culture from that drain came out as Klebsiella, and we had started culture-sensitive antibiotics at that moment. Now, from this moment on, whenever I say post-operative day, it is with regards to the first surgery that we had done, the damage control surgery. That is the gastrojejunostomy and the insertion of the feeding jejunostomy. So 2 days after the damage control surgery, the patient developed some hemodynamic instability. He had tachycardia at the range of 130. He had sudden onset of hypotension. BP fell down to around 90/60. And we noticed that there was altered blood in the RT aspirate, in the Ryle's tube aspirate. So we went ahead with, although at that moment there was no hemoglobin drop, we went ahead with a CT abdomen, and it was noted that there were clots in the stomach, and there was a intraluminal bleed into the duodenum. So with the help of our interventional radiologist, we went ahead to do an angiogram, and it was noted that there was active extravasation from the pancreatoduodenal artery, from the superior mesenteric artery and the gastroduodenal artery. These are the images of the DSA, and as you can see on the images on the right hand side, there are two coils placed. So that is at the level of the superior branches from the superior mesenteric artery, and the lower one is from the gastroduodenal artery. On the 5th post-operative day, from the day of the damage control surgery, it was noted that his serum bilirubin levels were rising. And when we had gone back, it was noted that it was serially rising. It was 3 after 48 hours of admission, then 4, 5, 6, 7. It gradually kept rising. And we done an imaging at that moment, which showed intrahepatic biliary dilatation. And at that particular juncture, we decided to conduct a multidisciplinary board to decide how to go forward in treating this patient. Whether if the patient develops any symptoms, do we have to go in or do we pursue an interventional route? So it was decided that if at any moment while the bilirubin is rising, the patient develops any symptoms of cholangitis, we decided to perform an emergency percutaneous transhepatic biliary drainage, PTBD. Unfortunately, on the evening of the 5th day, the patient did develop fever with chills, and so on subsequent day, we did perform an emergency PTBD, and the culture from the bile culture sent at that time was also positive for Klebsiella. Similarly, culture-specific antibiotics were started at that time. Now, following performing the emergency PTBD and during the course of the procedure, the patient did develop some hemodynamic instability. There was tachycardia and hypotension, and there was need to place the patient on high inotrope support. Once the procedure was done and the patient was brought back into the surgical ICU, we decided to electively intubate the patient, and the patient was ventilated overnight. Fortunately, his condition improved overnight and he was extubated in a matter of 6 to 8 hours. Following which his vitals were stable. There was no fall in hemoglobin. Now, on the 9th day of the damage control surgery, that is post-operative day 9, we noticed again blood-stained RT aspirate. And this time, we again went ahead with a CT abdomen and an angiogram with the help of our interventional radiologist. And it was noted that there was a bleeding from the first branch of the SMA. There was a blush discovered at the first branch of SMA, and that was successfully coiled. Now, during this period, during the period of post-operative day 9 and 10, once the second episode of bleeding was noticed, once the second episode of blood-stained RT aspirate was noticed, the patient did have melena. His hemoglobin levels did dip down to the range of 6. We had to give him multiple transfusions, packed red blood transfusions. But even in spite of all this, he was hemodynamically stable. His BP was being held at 110, 120. There was no requirement of any inotropes at this moment. There was only hemoglobin drop, and we had to give him multiple transfusions at this point. Now, a word of caution, during the second embolization procedure, while this first branch of SMA was being coiled, we were also advised by our interventional radiologist that if at all there is another intraluminal bleeding down the line, coiling would be a tedious process. So at this point, once the procedure was done and once the patient was hemodynamically stable, we sat down again to decide how to go about with his course of management. And it was decided that once, or if at all, God forbid, he does get bleeding, intraluminal bleeding, we were deciding to go ahead with surgery this time. Now, going on, during this rocky road, that was around period post-operative day 12 from the first surgery, these were his lab values. His hemoglobin was stable at 9.8, although there were multiple transfusions given. His total count was at the range of 21,000. Platelets were dipped to 55,000. This was in line with the culture reports that we had received. There was Klebsiella growing in his blood, in his bile, and also the intra-abdominal collection that we had drained. During this course of 3 to 4 days, we had slowly started him on enteral nutrition. The feeding jejunostomy that we had placed during the damage control surgery, we had initiated feeds within 36 hours, and it was gradually escalated. He tolerated it very well, and then we tried to slowly initiate him on oral feeds. As it was not sufficient, we did have to give him supplemental parenteral nutrition. Now, the reason why I'm bringing this up is because once we started the patient on enteral nutrition and the patient started tolerating the enteral nutrition, And in this clinical scenario, his electrolytes started becoming slightly deranged. That is, magnesium started falling around 1.3, 1.4. Phosphorus was on the lower side, 2.4. Although his potassium level is 4.7, we were constantly supplementing potassium on a daily basis. So that is the reason for the almost normal potassium values. I wanted to bring up the terminology of refeeding syndrome. That is the reason for bringing up the slide. So once we started the patient on enteral nutrition, he started tolerating the enteral nutrition, even the slight oral initiation that we had given. He had slight dyselectrolytemia, and this is just a small slide summarizing what refeeding syndrome is and what it is that we are uh, looking forward to once we initiate in enteral nutrition, and how do we go about with it. There might be a dyselectrolytemia for hypophosphatemia, hypokalemia, hypomagnesemia. All this because
What happened?
sorry.
How much?
Jithin, continue. There's somebody unmuted.
Okay. So as I was saying, this is just a slide summarizing what refeeding syndrome is. Now, refeeding syndrome, we usually base it on the phosphorus values once we initiate the enteral feeds. So in our case, it was a side, so we have phosphates. And how this translates into systemic manifestations, or how this translates into how this translates into manifestations systemically. In the GI system, a refeeding syndrome can manifest as an ileus. Respiratory would be in the terms of respiratory failure, dependence on ventilation, ventilators, pulmonary edema. Neurologically, he can have paresthesias, mild paralysis, weaknesses, seizures. So this is just an idea about what refeeding syndrome is and how it manifests in the various systems in the body. Now, coming to the crux of the presentation, on the 15th post-operative day, that would be the 15th post-operative day from the day of the damage control surgery, and maybe around 25 to 29 days of the day of onset of the injury that I mentioned initially, he again developed blood-stained Riles tube aspirate. He had vomiting, and the vomitus had blood clots in it. So at this point, considering the input from the intervention radiologist from the previous angiogram, we had decided that we would proceed with an emergency Whipples procedure at this moment. After exhausting all other possibilities. Now, during this time, as I said, the patient was started on enteral feeds. The patient was slightly improving, although there was refeeding syndrome. All that was tackled. We had shifted the patient out of the ICU, and he was brought out into the ward, and we were quite happy with his road to recovery. Although, like I mentioned, on the 15th day, this was his status. He developed vomiting with blood clots, and we decided to proceed with an emergency Whipples procedure. On table, we noted that there was a duodenal wall hematoma at the region of the second and third parts of the duodenum. There was a contained hematoma that was densely adherent to the colon, the mesocolon, and the retroperitoneum. We did not find any necrosis of the duodenal wall on the outside. However, once the specimen was taken out and we had just opened it to see what was happening, it was noted that there was a cavity within the walls of the duodenum, a cavity into which the bleeding was occurring, and from which the intraluminal bleed was happening, the reason for the blood-stained Riles tube aspirate. Now, the interesting thing about this procedure that we had performed, the Whipples procedure, because mentioned, so we were unable to, surgery. So we had approach as multiple, or there are different ways to approach. In case we had hello, is the slide visible?
Yeah.
Okay. So as I was saying, we were unable to proceed with the conventional approach to a Whipples procedure. So we had to go in with the SMA first approach. There are 6 different ways by which you can go into this SMA first approach. And we had to perform a bit of each of these 6 different procedures to perform the Whipples procedure. What I want to convey is that the conventionally where the cauterization is in the initial set of steps, cauterization and the excision of the uncinate process was the final and last step that we had to perform. We had first gone ahead with transection of the pancreas and the stomach. We had to approach inferiorly, superiorly from all these 6 approaches to get into that area. And the other option or the decision that we had to take was how to perform the pancreatico-jejunal anastomosis, whether we had to go with the PJ or PG. But at that time on table, since we were going ahead with an SMA first approach and we had already transected the pancreas and committed to a conventional Whipples, we thought of going with a PJ. Now, another reason why we did not go with a PG was because it would require a little more mobilization of the pancreas. As I had mentioned during the course of the patient's amylase and lipase levels were always on the higher side. There was always an element of pancreatitis. On table, there was some inflammation of the pancreas. So we did not want to disturb that. We did not want to create a chance for any post-operative bleeding. We took extra precaution and extra care to suture ligate all the vessels so that no pseudoaneurysm could be formed. So thinking about all these options, we went ahead with a PJ by dunking the pancreatic stump. Now, during this intraoperative period, we did not encounter any hemodynamic instability. The patient did not require any inotrope supports. He was placed on the ventilator on the night of the surgery, and he was extubated by the next morning. His blood gases were all satisfactory, and we are happy with his road of recovery at this point. In our hospital, as a routine, we perform drain amylase. We put in 2 abdominal drains, one at the pancreatical jejunal anastomosis and the other at the HJ site. So, and in a routinely for all these Whipples procedure patients, we perform drain amylase levels and drain bilirubin levels on the first post-operative day and the third post-operative day to see if there is any leak or not. Now, the drain amylase level on the third post-operative day, from henceforth, when I use the word post-operative, it is with it's with respect to the Whipples procedure that we had performed. Now, on the post-operative day 3, it was noted that the drain amylase levels were elevated on both the drains. The drains that we put on the left side and on the right side, 2 drains. The right side was more than the left side, as you can see. So I just wanted to bring out this slide about the pancreatic fistula classification. Since we had only elevated serum amylase levels and the drain amylase levels, it was just a biochemical leak. It was just a grade A pancreatic fistula. We did not require any intervention. There were no collections. We were happy with this recovery at this moment. I just wanted to bring out the slide just to show that it was a biochemical leak and there were no interventions done. There was no signs of infection, any no drainage was done at this moment. No organ failure also. On the 5th postoperative day, unfortunately, he did develop 2 episodes of hematemesis, and there was the Ryle's tube aspirate was bloodstained. Although he was hemodynamically stable, his heart rate and his blood pressures were in the satisfactory range. There was no require of any supports. His hemoglobin did dip down at the range of 6.9 to 7. He did require some transfusion, maybe 2 pints blood transfusion. But the point of the matter is that he was hemodynamically stable and there was no need of any inotropic supports at this moment. So, considering his past where he had 2 episodes of bleeding, intraluminal bleeding, there was a bloodstained artery aspirate, we just went ahead with the CT, we went ahead with the DSA. Because the CT that we had taken at this moment, it showed that there was some enhancement at the region of the PJ, probably a bleeding that had occurred and subsided by itself. So we went ahead with doing a DSA, and it showed no blush at this moment. This way, the images that were procured during the DSA at this time, since there was no blush, there was no active extravasation, we proceeded to manage the patient conservatively. This is just a slide to show the classification of PPH. So ours was an intraluminal bleed that had happened. It had presented as a Ryle's tube, bloodstained Ryle's tube aspirate. He did require transfusion of blood since his hemoglobin levels dropped. But even though we went ahead with the DSA, there was no embolization, there was no re-laparotomy, anything. So we were grading this as grade B, post-pancreatectomy hemorrhage. Now, following this, once this scare was over, once we were out of the wind, we slowly started initiating the patient with oral feeds. Like I said, the feeding vaginostomy was already there from the first surgery. Immediately after the Whipples procedure, 36 hours, we slowly initiated him on enteral feeds. There was some requirement of albumin, there was some requirement of parenteral nutrition, and slowly and gradually we did start him on oral feeds as tolerated by him. Very minimal feeds, but something to go in. Now, on the 10th postoperative day, that is the 10th day from the day of the Whipples procedure, it was noted that he developed a fever, there was nausea and vomiting, multiple episodes of vomiting, and there was tachycardia. We were unsure at this time as to what was the cause for this. His labs were gradually improving. Like I mentioned, there was a sepsis, the culture-specific antibiotics were given, the counts were gradually on the declining trend, so the procalcitonin levels were coming down. So there was no, we were not expecting a sepsis at this point, so we were unable to figure out what was the reason for these symptoms. So we went ahead and we took a CT of the abdomen on the 10th postoperative day, and it was noted that there was a retrogastric collection. These are the images that were procured in that scan. This was in the region of, it was in the lesser sac, behind the stomach, and there was no association with the pancreas. So there was, it was not a leak from the pancreatic duct or from the pancreas. So there was a retrogastric collection, and we assumed that this was the reason for the fever. It was a loculated collection as suggested by a radiologist. So we, with the help of an interventional radiologist, we did put in a percutaneous drain, and it was drained. We changed the antibiotics based on the culture. We had taken a repeat CT scan over the course of a few days, and it was noted that the collection had decreased in size, as you can see in these images. Still present, but decreased in size. So once this collection decreased in size, and once the collection was drained, the patient started getting his appetite back. The nausea and vomiting that I initially mentioned, that subsided. He was able to take oral feeds. It was gradually escalated as per his tolerance. We were slowly able to taper down on the supplemental feeds that we're giving. Mind you, during all this time, we were giving constantly enteral nutrition through the feeding jejunostomy that we had placed initially. So I just wanted to bring out this slide about the classification of delayed gastric emptying. In this case, we did take out the Riles tube and we had to put in the Riles tube again. The Riles tube was there for a period of around 10 to 14 days. So we had graded this as a grade B DGE. Now, following the drainage of that retrogastric collection, the patient did improve. The patient did start taking oral diet. It was gradually escalated to soft diet. We were able to taper down on his feeding jejunostomy feeds only as and when required, or whenever his oral intake was on the lower side. We were able to de-escalate his antibiotics. His pain was managed. There were no signs of bleeding. His hemoglobin was stable, and there was some thrombocytosis that we had noticed along at the time of discharge or during the time of discharge. His platelet count was in the range of 6 to 7 lakhs. In spite of all his other parameters being within the normal range, his serum amylase and lipase, even at the time of discharge, was in the range of 150 to 200, 250. At the time of discharge, it was at the range of 300 and 400, but patient was not symptomatic. His vitals were stable, and he was tolerating orally. So we decided to discharge the patient after almost a month and a week, with one abdominal drain and the feeding jejunostomy in place. This was the final histopathology report that we had received following the Whipples resection. It was an intramural hematoma of the duodenum with acute and chronic inflammation seen. It has been quite a journey with this patient, and the patient is still on a regular follow-up with us. It's been around 2 to 2.5 months now, and patient is clinically much better. He is taking orally. He has gained weight. We had removed the abdominal drains gradually once his amylase levels, where his drain amylase levels and the drain output had come on the lower side. Even now, over the last 2 weeks, he did come to visit us, and he has improved much better, and he is almost back to his normal self. Although one concerning factor is, even during this time of discharge and during the review process, during the follow-ups, his amylase and lipase levels were still on the higher level. His amylase during the first initial visits were at the range of 200 and 300. Over the last few months, it has come down. Even though it has come down, it is still at the range of 140, 150 even now. So that brings the end to the story of our patient. So I just wanted to bring out some facts with regards to pancreatic injury and duodenal injury before I wind up. So the incidence of adult duodenal trauma that is documented in the literature that I could find was around at the range of 0.2 to 0.6%. And duodenal trauma is always associated with other injuries, the most common being injury to the liver. So the associated injuries range between 68 to 86%, and there are some vascular injuries involved in the range of 23 to 40%. On the other hand, adult pancreatic injury is less than 1% of the documented cases that we could find in the literature, and it is almost often, if not every time, is associated with another injury with it, which is usually of vascular origin when it comes to a pancreas. So this is just a paper that we had found from the World Journal of Emergency Surgery, the World Society of Emergency Surgery, and the American Association of Trauma. They developed a guideline, more sense, about how to go about with duodenal injury or pancreatic injury. And they combined it so that we could have some sort of an algorithm on how to go about with it. So the key takeaway points from this particular paper was that they suggested that the amylase and lipase levels needs to be measured every 6 hours. They also suggested that the accuracy of understanding whether the amylase lipase levels are elevated or not, it's most accurate when it is measured 3 hours after the injury, not immediately after the injury, but 3 hours after the injury. In our case, we did not plan for that because the patient presented to us 4 hours after the onset of injury. Again, from this paper, another point is that the efficacy or the accuracy of a CT scan with respect to pancreatic duodenal injuries. There is a sensitivity of 86% and a specificity of 88% with terms of a duodenal trauma. This sensitivity dips to around 52 to 54% when it comes to pancreatic trauma because the duct, it is difficult to delineate the duct in the CT scan, is what they say. So this is the American Association of Trauma, the classification of pancreatic and duodenal injury. In our case, like I mentioned initially, from the outside CT reports and with subsequent CT reports done at our hospital, the patient had a grade 2 duodenal injury, a grade 2 duodenal hematoma, because more than one portion of the duodenum was involved. Mainly, there was a narrowing of the third part of duodenum, but the second part was also involved. So it was grade 2. And there was some major contusion without any duct injury or tissue loss of the pancreas at the region of the head, as I mentioned. Grade 2, pancreatic injury. Now, in what the AAST says is when there is multiple organs involved, your grade 1 will have to be stepped up to grade 2. Your grade 2 will have to be stepped up to grade 3. So where we were presented with grade 2 pancreatic, grade 2 duodenal injury, grade 2 hepatic injury, based on these guidelines, what they mentioned, we'll have to upstage the grade to grade 3 injuries. It's just a note that I wanted to put out. Now, in that same paper, the Journal of Emergency Surgery, they classify all these injuries into another classification, WSES classification, class 1, 2, and 3, minor, moderate, and severe. In the case of our patient, since he was having AST grade 2 duodenal injury, it would come to moderate WSES class 2 classification. And this was the algorithm that they had shared in their study. Whenever a patient presents with hemodynamic instability or patient is unstable, there is evidence of evisceration of bowel. There is evidence of intra-abdominal collections because of some perforation. It is always advised to take the patient directly to the operating room and proceed as how the case presents. In our case, the patient presented to us 4 hours after the onset of injury. The patient was completely hemodynamically stable during the initial time. There was no need for us to push the patient into the operating room at this moment. So we had proceeded to go with a CT scan after 48 hours to reassess the injuries, to grade the injuries, to see what is happening inside his abdomen. Now, like I said, in this particular patient, it was a WSES class 2 classification. It was a moderate lesion. So we had performed a repeat CT scan and to decide on what is the accurate or the correct way to go about with this case. Now, one thing I want to bring about is that this particular paper, it just gives whether or when not to take the patient into the operating room. It does not give us any input on how an interventional radiologist can help us in case something happens, what has happened in our case. So if you can see in this particular flowchart, in this particular algorithm, when you have an AAST grade 2 repair, grade 2 injury of the duodenum, they are considering primary repair at that moment. In our initial CT scans, it was shown that there was the initial CT scan that was done from outside. There was a blotch of contrast into the periduodenal collection. In our subsequent CT scan that was taken 48 hours after, there was no active contrast extravasation. So there was no, we decided there was no need to go ahead to go with a primary repair. We decided to go ahead with a conservative approach, a non-operative approach as far as possible. We were aware that at one particular point we will have to go in for a definitive surgery, but in the meantime, we wanted to go ahead with a non-operative management as possible. But the patient did present with gastric outlet obstruction. We had to go in for just a damage control surgery. We go in to perform a laparoscopic assisted gastrojejunostomy. We put in a feeding jejunostomy for his feeding purposes. So that was just from that particular paper. So there are multiple papers that talk about duodenal injuries, that talk about pancreatic injuries, but we could only find a handful of papers that talk about pancreatic or duodenal injuries, the two of them combined, and how to proceed with them. So summarizing all these papers, what we could find that the most common duodenal injury is because of penetrating trauma. There is around 53 to 90%, and an immediate mortality in this subset of patients is due to hemorrhage from a major vascular pedicle. Early mortality is because of hemorrhage, late mortality because of some leak, presenting as an intra-abdominal sepsis or fistulas. Mortality in that they document in these papers is in the range of 15 to 47% in the case of a duodenal injury. The most common duodenal injury that they have seen in their series is the second part of the duodenum, followed by the third, and then finally the fourth part. Again, summarizing from these papers, one of the common findings that I found is that whenever there is a delay in the diagnosis of more than 24 hours, the mortality increases to 40%. In that range. On the other hand, if we are able to come to a diagnosis about what is wrong with the patient, about an accurate diagnosis in less than 24 hours, the mortality decreases drastically to only around 11%. So the most important thing is to identify the injury and to see how to go about with it rather than delaying the diagnosis. Now, this was very pertinent in our particular patient. In these papers, what they have said says that if there is a duodenal hematoma, they suggest to observe the patient, because usually the duodenal hematoma will resolve in a period of 2 to 4 weeks. If it does not, if the duodenal hematoma does not resolve in a span of 4 weeks at the most, they advise us to go in for surgery to relieve the hematoma and to perform a primary repair or a bypass. In our case, the patient did present with gastric outlet obstruction because there was a significant narrowing of the third part of the duodenum. So we did go in, but considering that there was an acute inflammation of the pancreas at that moment, we did not want to do any major surgery. We just wanted to go in, bypass, come out, and provide an access for enteral nutrition. So these are the various surgical options that one has when it comes to duodenal injury. You can go for a duodenographic primary repair. You can place a duodenostomy tube. There is this triple ostomy technique. This is a triple tube duodenostomy technique where an NG tube is placed, a retrograde jejunostomy is placed to drain the distal duodenum, and also an antegrade jejunostomy is placed for feeding purposes, to provide enteral nutrition. Then there is the duodenal diverticalization procedure, as mentioned by Burns. Here, the duodenum is primarily repaired, a duodenostomy is placed. At the same time, there is a T-tube placed into the biliary tree, and antrectomy is performed with or without a truncal vagotomy, and also a gastrojejunostomy is formed. Now, and find one of the other things that they talk about in these papers is that in their series or in their review of literature is that pyloric exclusion with gastrojejunostomy. Again, an absorbable suture or stapler is placed at the pylorus and a gastrojejunostomy is formed, which gradually gives way over the course of a few weeks. Now, even though we did not perform these procedures as mentioned on this slide or in the slides previous and after, in a way we did perform all of this. We did perform we did put in a nasogastric tube. We did divert the bile when the patient presented with cholangitis. We did provide an enteral route for feeding. All these were done on separate occasions, but all these were done for our patient. So what I wanted to say is that when we go through these papers, they do give uh, a synopsis about all these different procedures and what is the mortality rate, what is the morbidity rate. The Burns diverticulization procedure, there is a mortality of 17%, and they don't suggest performing all these procedures now. They want to try to go with a non-operative management as far as possible, and if required, to step in and perform a definitive surgery. When it comes to pancreatic injuries, it is almost certain that when there is a distal pancreas involved, we have to perform a distal pancreatectomy. When there is a head of the pancreas involved, maybe a Whipples procedure. But the question here is, how do we proceed when there is a duodenal injury, and how when there is a duodenal injury along with a pancreatic injury? So the final thing that I would like to share is that in such cases, it was a experience for all of us. Almost 2 to 3 months were spent behind this patient, and there were multiple things that had come to us, which I don't think without this patient we would have not thought of. So it was what we realized, it was a multidisciplinary approach that was required. We have to call in all the specialists. It is not just our work. Everyone needs to be involved in it. And most importantly, one point that I want to convey is that an interventional radiologist can do a lot of things to help us in this non-operative management to prevent a major surgery. Yes. Thank you.
Thank you. Thank you, Dr. Jitin. That was a very extensive coverage of pancreatoduodenal trauma. I think there were some questions in the chat box. Somebody was asking about the drain and all. But before going into the... Hello, Jitin, can you hear?
Yes, sir, I'm here, sir.
Before going into the chat box, I have a few doubts. First of all, to begin with, this was a very early grade duodenal injury. And anyway, you have decided to do some surgical procedure. And by the end, what I understood is that the Whipples procedure done in this case was the actual damage control procedure rather than the other damage control procedures. So why didn't you think of complete exploration in the first instance itself? Because if we open a case like this in early part of the trauma, like 48 hours or 72 hours, your intervention would have been much less compared to the delayed management of cases like this. So in your opinion, what should be the best option? Is it doing the extremes of conservatism, spending all money of the patient, doing all the interventional procedure, which may not be available in many centers, or go ahead with a straightforward pyloric exclusion and T-tube drainage? That was the one which we do in the surgical, MS surgical days.
Yes, sir. So when this patient presented to us with these particular injuries, we were almost certain that it's going to end in a Whipples procedure. We were almost certain that there will be a definitive surgery involved. But there were some concerns that were with us at that time during the initial phase. First being that there was a contained, as I mentioned in the CT reports, there was a contained hematoma at the periduodenal region. There was no active contrast extravasation. There was some contrast that was being leaking into that particular collection. Now, again, I said there was amylase and lipase levels are also elevated. So all these factors, when we factored in, it did not seem wise to go ahead with a major surgical procedure at that time. That was our thinking process at that time. So we thought, since anyway the patient did present with a gastric outlet obstruction at that time, we did drain the collection, but the hematoma was left untouched. We did not drain the hematoma. We did not want that to come into the abdomen. There was an we wanted whatever bleeding was to happen, let it happen intraluminally so that the abdomen was not touched. That was our aim behind it.
Hello, can I add, sir?
It's open for discussion. Yeah, you can.
Murli, sir, actually the issue in this patient
Yeah,
was,
Murali.
sir, I'm Murli, sir. Can I add, sir?
Yeah, you can. Yes.
Sir, actually the problem with this patient was that we were knowing like there was a duodenal content perforation was there, and also recurrent pancreatitis at the pancreatic or duodenal groove causing pseudoaneurysmal bleed. So when we went ahead, we know like we may have to do a Whipple, but at 2 weeks whether a Whipple was safe, that was the issue. How to handle the pancreatic stem, that was the question. So we wanted time. So we wanted at least 4 weeks, because in pancreatitis itself now it's step-up approach we are following. We need to take care at least 4 weeks. After that only we'll do surgery. So we thought like we will wait maximum with interventional procedure and then go ahead with surgery, because this we have extrapolated from our experience in the liver injury. We have almost managed around 25 grade 4 liver injury without surgery, successfully, without any mortality. So we thought like if you have a interventional radiology backup, we can buy time. So what we did was every time, every 5 or 6 days, he was bleeding. Bleeding was just because of the recurrent pancreatitis in that duodenal groove. Pancreatic arcade was getting pseudoaneurysm formation was happening. It is bleeding into the duodenal wall and intraluminally. Always we want that we can pick that thing through the Riles tube aspirate. That's why we kept the Riles tube, even though he was not having any issues. Even after the postoperative Whipple procedure also we kept. Initially there was no nausea, vomiting or anything, but the day 5 we picked it just because the Riles tube aspirate came positive, blood stain. So we were knowing like by buying time with interventional radiology. So that's why we didn't do Whipple at that point. Initially we had a concern like whether to open that hematoma and everything. So we thought like it was not safe, because if it was bleeding externally, we should have done a Whipple procedure earlier at day 10, day 15 or day 20. And I don't think we would have been able to do a good pancreatic anastomosis. So since we have waited for day 28, the surgery Whipple we have done, it was on day 29. Actually, intraoperatively, there was no bleeding. Only thing was to the approach of the pancreas was little difficult. But we could, after superior approach, we cut the pancreas and we for hepatic artery, portal vein dissection, SMA, SMV, everything we identified. Then the last part only we could go to the retroperitoneal area. There was no bleeding intraoperatively just because all the major branches of the SMA we have embolized, and rest of the things I could ligate it from above. Even the GDA branches were embolized initially. The second time when we have bled, one more thing, it was like we did a DSA, even though there was no blush, we kept the catheter there. So we were planning like if there is any hemodynamic instability, we'll go ahead, even thought about embolization of the splenic artery prophylactically if it was bleeding. But we could not find any literature. We were going that much aggressive. But luckily, that time the bleeding got controlled. So initially, at 2 weeks of time, we were a little skeptical to go ahead with the Whipple, and because even I don't have experience with emergency Whipple, so I thought like we need time. So we have interventional radiology backup all the time. So I thought like it is better to go ahead with a non-operative management with a stage surgery. First, we did a damage control surgery. We put a drain in the periduodal area so that if there is any perforation or anything, we can make it a control fistula. Just like a duodenal diverticulation and everything, the basic concept is like collection. We have made it a fistula. The bile has been drained with the PTBD. We didn't do a pyloric exclusion because the bile was coming to the stomach and we did a GJ. Through the GJ, it was draining. If you were doing a pyloric exclusion at that time, it was because the D2, D3 is already blocked. So at that time, we didn't. The bilirubin was around 3 to 4 only. So we didn't disturb the bile duct also. Just because of the recurrent pancreatitis, he developed HPID. There was contrast at the cholangiogram. When we did the PTBD, it was drained to the duodenum. But because of the ascending infection, he went to the cholangiotus. So we had a biliary drainage, we had stomach drainage. I put the Riles tube also. Pyloric exclusion we didn't do just because we want the bile or whatever collection the duodenum or pancreatic secretion, it has to come to the stomach and drain to the GJ. And we have put a drain, JP drain after washing in the damage control surgery, all the collection hemoperitoneum which he was having, we have drained it out. And if there is any contained leak happening, it has to drain out. So we can control it like a controlled fistula. And also we have a portal for a feeding jejunostomy, just like the concept in duodenal diverticulation, the concept in tracheostomy, everything we have followed, and with the help of minimal interventions, staged procedure. So we could do a Whipple and come out without bleeding, just because we have done it in a staged manner. So, and we could not find any literature, because we know, like, even in pancreatitis previously people used to do early surgeries. Now it has come like a step up approach. So I think in duodenal trauma and the pancreatic trauma, it is there, we have to always go for a non-operating and a step up approach if feasible. So if interventional radiological procedures are not available, I think we may have to go, we have to drain that. Even at 2 weeks itself, we may have to drain those collections at that point itself. Since we have not done that thing, and all the bleeding has started after the damage control surgery, so that's why we followed in a little more non-operative management. We tried to avoid surgery. Sir.
Thank you.
Sir. Hello, sir.
Yeah.
So that's why we delayed the surgery, sir. Initially, we had a discussion at day 14 whether to go ahead, whether intraoperatively. I was not sure whether I'll be able to control the bleeding, because the issue was to get into the retroperitoneum, into the vessels. The bleeding, whether I'll be able to control the bleeding, because in the DSA itself, I found the gush was too much into the duodenal lumen when he was pushing the contrast.
Okay, we have many senior GI surgeons in the audience. I think we can have inputs from Dr. Prakash, Dr. Joshi, Shubhalal sir. Prakash sir? Dr. Prakash.
Hello, yeah, I have sent you some comments also. To me, the picture is not clear. Sorry to say, Murli, the CT pictures you haven't shown. Only 4 cuts in a single window is not sufficient to make the audience understand how much bleeding was there.
Yes,
you
sir.
could have played a good video showing that there is a bleed in the duodenum,
Yes,
and
sir.
neither we could see any pseudoaneurysm in that level. And you have already embolized the jejunal branches as well as GDA branches, so that should have reasonably managed that bleed.
Yes, sir.
And I could not understand that the idea of jejunostomy, gastrojejunostomy, because the duodenum hematoma has produced the temporary gastric outlet obstruction. It usually resolves conservatively unless it is bleeding. And later on in the course, I would have definitely advised the endoscopist to go in and see whether there is any ulcer or anything bleeding, and they could manage it endoscopically as well. So these are my thoughts. And if at all I'm operating, I would have, if there is an indication to push us to open up this patient, it would have been Whipple the first go itself. That's my comment.
Sir, sorry for that. We couldn't put the CT because we thought like it will be a problem for uploading, network issue. That's why we put the images only. And one thing, sir, we did a GJ just because the Riles tube aspirate was around 2 liters are coming. It was bile and nothing was going across the D2, D3. That's why we did a GJ.
But such hematomas eventually resolve unless it's bleeding actively or it resolves and duodenum opens up. So
Yes,
GJ,
the issue was,
I don't know.
Every 5 days, the patient is bleeding again and again.
Yeah,
so,
bleeding part is different. I'm talking about GJ part.
GJ part, okay, sir. So GJ, we just did it mainly for nutritional part and also for that Riles tube aspirate was high. That's why. Because the literature, what we found, like people are telling like to go and do the hematoma repair. So we don't want to repair anything like that. So we wanted to go ahead with the non-operative management, sir.
Murali, there was indication for some air pockets in the retroduodenal area, as per your
definitely it was there.
So
Sir.
when there is air pockets, there was some transmural injury to the duodenum. It may be in the pancreatoduodenal area.
Yes, sir. Definitely, I do believe that.
I think doing Whipple in the first 72 hours after trauma is easier than doing a Whipple after 29 days of your surgery. It's easy to identify the pancreatic stem. And I do disagree with Jitin saying that it was grade A pancreatic leak. Because it was grade B, because you have to do some intervention for a collection. So you didn't mention about the amylase lipase in that collection, and there was persistent hyperamylasemia after Whipple. So if there is a collection, persistent amylasemia, hyperamylasemia, and you had to do some intervention, that can be only grade. The grade is not grade A. It can be grade B or grade B. Okay.
So the amylase of that fluid was normal, sir. That's why we made it grade A. But I do agree, sir. If intervention comes, we can make it grade B, sir. Definitely, sir.
So far, I have done only one Whipples for a pancreatoduodenal tumor. That was within 24 hours of surgery. Because identifying the duct will be a difficult issue, because most of the time there may not be any ductal dilatation or any disease process. But we don't have to worry about the margins and other thing in an emergency Whipple. We need not go very close to the superior mesenteric artery. We can use just like resection with some amount of pancreatic parenchyma. Nothing will happen in those situations.
Sir, if there was a grade 3 injury, definitely pancreatic injury, there was no confusion. The problem was that grade 2 injury, that the pancreatic or duodenal groove.
No, he was mentioning grade 2 will be upgraded to grade 3.
Yes, sir.
When you have three organs injured.
Yes, sir. Definitely, sir. So the most common here, the duodenum, we thought it like we'll upgrade it, sir. Duodenum grade 3. So it was because we have extensively surgery literature. Maximum what we found, like it is better to go ahead with the non-operative management, and the multidisciplinary meeting also everyone preferred for a non-operative management because of the trauma cases how we have managed because of that.
No, everybody gives importance to Murali.
Yeah, yes, sir.
Everybody gives importance to the ductal disruption in the pancreatic head, but contusion, a major contusion which damaging the pancreatoduodenal artery into the pancreatic parenchyma is equally dangerous as a pancreatic ductal injury in the head. Yes, I think we have to go by that also.
Okay, sir.
Right.
Hello.
Yes.
Yeah, can I make a comment? Shabir here. Yeah. Hello.
Yeah, sure.
Okay.
Sure.
Murali, it was a very difficult case, and I know how much stress you might have faced while managing a small boy, 17-year-old with all these things. And it was very well managed, I think. And it is easy to make comments retrospectively. But one comment I would like to make is, as Prakash sir, I think, and Pradhavan sir also mentioned, even in an endoscopic injury, if there is a contrast leak into the retroperitoneum, I also have a reservation for managing it conservatively, whatever be the grade of injury. Even endoscopic injury guidelines, if we see only air pockets, we may be able to manage. We can manage. But these type of patients have a high risk of developing sepsis. And I have seen 1 or 2 patients who have a missed duodenal injury suddenly collapsing and dying. Even we may not be able to resuscitate such patients. So I have a reservation even in endoscopic injury, if there is a contrast leak, uncontrolled contrast leak into the retroperitoneum, and I think which has to be explored early.
Okay.
So it was a nice case, well managed. Finally, patient went home well. Thank you. Over to Dr. Pitambar.
Thank you, sir.
Thank you, sir.
Yeah.
Thank you, Dr. Prathapan, for moderating this session, and it was a wonderful case. And as Shabir already told, it is very easy to analyze it retrospectively. What I probably, my comment probably is that since there was air pockets and we had already explored, I think it would have been better to at least drain the hematoma and see if there is any bleed. That's my opinion. Maybe you are the better judge on the table. And I don't know whether Dr. Joshi has left or not. He told he will be leaving early. And I sincerely thank everyone, Dr. Prathapan, Dr. Murli, Dr. Jitin, Prakash sir, Shabir Ali, for discussing this one case wonderfully and in giving the inputs. Thank you, everyone.
Thank you, sir. Thank you.
Thank you, sir.
Good night. Happy Sunday.
Thank you.
Thank you. Hi, Pradhan sir. Bye.